Hi, good evening. Thanks for joining us. I want to welcome you to our elbow arthritis webinar. My name is Jadie De Tolla. I'm a hand surgeon at NYU. We have an exciting lineup of faculty presenting from NYU tonight. I will be giving the first talk on the evaluation and non-operative management of elbow arthritis. Can we switch over to my slides? Great. Okay, I have no disclosures. My talk will focus on how to critically evaluate and diagnose the most common etiologies of elbow arthritis. I will also briefly touch on the non-surgical management of these conditions. The three most common causes of elbow arthritis include primary osteoarthritis, post-traumatic arthritis, and rheumatoid arthritis. Other less common etiologies include Charcot arthropathy, crystalline-induced arthropathy, and hemophilia. Symptomatic primary osteoarthritis of the elbow is relatively uncommon. There's a prevalence of about 2 to 3%, and it occurs predominantly in middle-aged men and is closely linked with manual labor and other strenuous or high-demand activities. Post-traumatic arthritis is a more common entity. We see this following intra-articular fractures of the distal humerus and fracture dislocations of the elbow. Rheumatoid arthritis is a systemic inflammatory disease characterized by a chronic erosive polyarthritis. Elbow involvement is present in approximately 20 to 60% of rheumatoid arthritis patients, with 90% of these patients having bilateral involvement. Most of us know that the introduction of disease-modifying anti-rheumatic drugs have dramatically altered the course of this disease process by slowing disease progression and severity, with some patients even achieving complete resolution of signs and symptoms of RA. This has resulted in a significant decrease in the number of patients requiring reconstructive procedures, particularly in the upper extremity. That being said, today's patients present us with a new therapeutic challenge because they are more active, have higher expectations, and are placing greater functional demands on their reconstructive procedures relative to patients in the past. A detailed history and physical exam is critical for diagnosis and guiding effective treatment. A discordance between clinical and radiographic findings is a common finding in elbow arthritis. If you treat the X-ray alone, you could end up performing the wrong procedure and fail to meet the needs of your patient. Characteristics to understand about your patient include anything related to their functional demands, as well as a thorough assessment of their understanding of what high demand activities consist of. You need to ask about profession, if they're involved in any heavy labor or hobbies such as weightlifting, and you need to know if they use walking aids and have caretaker responsibilities. You should also assess for disease severity and identify the primary complaint. Is the primary complaint pain, or is it stiffness, or is it both? And also you need to assess for instability. Importantly, you need to know where along the arc of motion all of these symptoms occur. On physical exam, you need to make sure you assess for old surgical scars as well as deformity. I find that sometimes patients forget they had surgery. Sometimes they have a previous ulnar nerve decompression and they won't remember. So you need to look for the surgical scars. It's important to record both active and passive range of motion with a goniometer and to evaluate stability, strength, and perform a very thorough neurovascular exam. Another thing you don't want to miss is examination of the wrists, because you don't want to miss an old Essex Lopresti injury. Key symptoms to recognize in early primary osteoarthritis include pain and loss of motion at terminal flexion and extension related to osteophyte impingement. Loose bodies may also lead to catching and locking of the extremity. Key findings on exam include flexion contractures and concomitant ulnar neuropathy, which is present in around 50% of patients. In addition, assessing for ulnar nerve subluxation and a history of ulnar nerve transposition is critical, as this may be a contraindication for elbow arthroscopy. Pain in the middle range of motion and loss of form rotation can be seen in osteoarthritis, but these are really only present in the later stages of the disease process. Rheumatoid arthritis is an autoimmune disease that attacks the synovial tissue. In this chart, you can see that over time, the expansion of the autoantibody profile leads to increased immune cell infiltration, synovial hyperplasia, and pannus formation. This chart just shows how, depending on the severity of disease, patients have different presentations. So in early disease, patients have an isolated synovitis, which causes swelling, pain, and loss of motion. With persistent synovitis, you start to get soft tissue attenuation, and this can lead to instability and deformity, as well as ulnar neuropathy and PIN palsies. In late stages of disease, articular cartilage erosion and bone loss results in pain throughout the arc of motion, progressive stiffness, and worsening deformity. This slide just reinforces some of the key symptoms and exam findings I had mentioned previously. I want to point out the importance of asking the patients about ipsilateral shoulder, wrist, and hand pain. You need to give careful consideration to the order of surgical staging in patients that have multiple joints that are indicated for reconstructive surgery. So for imaging, plain radiographs are the primary imaging modality used for evaluation of elbow arthritis. In RA, you need to make sure preoperatively you get C-spine imaging. CT scans with 3D reconstructions are helpful for showing heterotopic ossification and localizing loose bodies. And these can be helpful, but they're not always necessary. MRI is sometimes used. It's not really essential for diagnosis, but it can be helpful for identifying synovitis and also assessing articular cartilage changes in early disease. You can see in the photos on the bottom, severe synovitis of the joint in a patient with RA. Radiographic changes in rheumatoid arthritis can be graded with the Larson or Mayo clinical classifications. Typical radiographic findings include symmetric joint space narrowing, osteopenia, periarticular erosions, and progressive joint destruction, which you can see depicted in the radiograph on the bottom right. Typical radiographic findings in primary osteoarthritis begin with osteophyte formation at the olecranon and coronoid processes and fossas, in addition to loose body formation. In advanced stages, you start to see involvement of the radial ulnar and radiocapitellar joints. Rettig and colleagues actually described a radiographic classification system for rating the severity of primary osteoarthritis. In their investigation, the authors found that the effectiveness of open debridement and capsular release diminishes as the class or severity of disease progresses. Okay, on to non-operative treatment. So non-operative management of elbow arthritis is similar to the standard treatment of arthritis elsewhere in the body and should be exhausted prior to concerning operative intervention. Medical management includes the use of anti-inflammatories and other non-narcotic analgesics. Intra-articular cortisone injections are helpful, especially in the setting of acute flares. And probably the most important thing is the early and aggressive medical management of rheumatoid arthritis with DMARDs, which is now the mainstay of treatment. In osteoarthritis and post-traumatic arthritis, activity modification should be encouraged both at work and with hobbies in an effort to limit or delay further degeneration and pain. Therapy plays a role, particularly in post-traumatic arthritis, in this setting to help maintain whatever range of motion they have. And also sometimes well-informed therapists can educate patients on ways to modify day-to-day activities in an effort to decrease forces across the joint with the aim of decreasing pain and slowing degenerative changes. Okay, so now we'll move on to operative management. Okay, so it's my pleasure to introduce our next speaker, my hand surgery colleague and mentor, Dr. Nader Paksima. Dr. Paksima is a professor of orthopedic surgery at NYU and the director of the Hand and Upper Extremity Center at Langone Orthopedic Center. He will be speaking to us about open debridement of the elbow for the management of arthritis and stiffness.
Thank you, Dr. Tolla. It's a pleasure to be here. And let me see if I can advance. Oh, there we go. Sorry. These are my disclosures. And I'm going to talk to you about the stiffened arthritic elbow. And elbows, as you can see, can be used for all kinds of things. The majority of cases that I see are either from post-traumatic cases like heterotopic ossification or post-traumatic synostosis. And there are a minority that present from arthritis as well, as you heard earlier. So here's an elbow that has sustained a dislocation and then can go on to develop post-traumatic heterotopic ossification. And here's a X-ray of a osteoarthritic type elbow. Etiology of elbow contractures can be related to soft tissue, such as capsular contractures. They can even be related to hematomas and infections. And they can also be bony causes like heterotopic bone, periarticular calcification, and things like arthrogryposis. Now, we want to differentiate between periarticular calcification and HO, or myositis ossificans, because periarticular calcification, it doesn't turn into organized lamellar bone, but heterotopic ossification does. There's a cellular center, there's a secondary layer of osteoid, and then a peripheral organized bone that eventually forms. The pathogenesis is thought to be related to undifferentiated mesenchymal cells, and they're modulated by these cytokines and proteins. Alk Phos levels were historically important. We used to monitor Alk Phos levels with regards to heterotopic bone and see how they would stabilize, but they're probably less important right now and just of historical interest. There is a transient elevation of serum protein and a decrease in serum calcium that can be seen in the early stages. Heterotopic bone doesn't show up on plain films for the first few weeks. So if you get an X-ray before 4 or 6 weeks, you might miss it. And bone scans, again, are of historical interest. We used to follow bone scans and wait for them to get cold, but that's no longer thought to be necessary. And delaying treatment of heterotopic bone until maturity, which we used to wait 18 to 24 months for, is not necessary. HO can be classified by its function, and class 1 has no functional limitations. Class 2 is broken into A, which is a limitation in the flexion extension plane. 2B is limitation in the supination pronation plane, and 2C is in both planes. And class 3 is when you have frank ankylosis of the joint. And again, bridging in one plane is better than bridging in 2 planes. You can also think of HO by its location. So is it anterior, involving the coronoid and the brachialis? Is it posterior, involving the olecranon process and forming a bridge between the ulnohumeral joint or the triceps insertion? Or is it on the radial and lateral sides, like from the collateral ligaments? So here's a case. This is a fracture dislocation of the elbow, which was treated a long time ago with this hinged compass hinge external fixator, a radial head arthroplasty, and suture repair of the collateral ligaments. And it conferred stability to the elbow, but you can see at 1 year that there was some heterotopic bone that's formed here anteriorly, medially, and radially, and causing a limitation of range of motion. So I'm going to concentrate on the surgical treatment of heterotopic bone in terms of excision of the heterotopic ossification. And you can kind of think of it by location, whether we're going to go in the front to remove coronoid osteophytes and release the brachialis and the anterior capsule. We're going to go in the back with the olecranon, or on the radial and lateral sides, looking at the collateral ligaments and their contribution. Most of the elbow stiffness that's associated with post-traumatic heterotopic bone can be addressed with a lateral and anterior approach. So it's a lateral approach, and then you can go in front and release the anterior capsule and take care of the coronoid, and you can go in the back and take care of the osteophyte and release the posterior capsule. And you may leave the collateral ligament in place or take it down and repair it on the way out. So here's what it would look like if you leave it in place with an anterior and posterior approaches. Let's look at some cases. So the first case is a capsular contracture without heterotopic bone. The x-rays look good on this case. She's a 53-year-old homemaker, and you can see these are x-rays taken from top to bottom. In other words, we're looking from the patient's head towards their feet. So the surface of the elbow that you see is a lateral surface. So there's a 30-degree extension deficit and 80 degrees of passive flexion. And it's always important to do the range of motion testing after anesthesia to see if there's a difference between pre-anesthesia and post-anesthesia range of motion. So here, the lateral approach was undertaken, and by going in front of, anterior or posterior to the supracondylar ridge, you can go and get the anterior capsule and relieve any contractures there. The purple dot represents the origin of the lateral ulnar collateral ligament, which can be preserved or taken down to get better access posteriorly. Here she is after a release with a full restoration of elbow extension and flexion. There's another case, another stiff elbow, post-dislocation, this time with heterotopic bone formation. I'll show you the x-ray in a minute. So here's the post-anesthesia examination of range of motion. You can see the flexion extension deficit, good supination, but the patient is missing pronation in the bottom left photograph. Here are the x-rays. So when I look at these x-rays, I think to myself, all right, where am I going for? What's the target here? And the target here is going to be the proximal radial ulnar joint to restore forearm rotation, and all the heterotopic bone that's in the anterior and posterior aspect of the elbow. So you plan your incision accordingly. This was a lateral approach through a cochlear interval. And here in the top right, you see going in the front, removing the anterior capsule, removing the heterotopic bone, and then a radial head arthroplasty was done to take care of the proximal radial ulnar joint. And here's the range of motion with full flexion extension and full supination and pronation restored. Now, whatever range of motion you gain, you lose about 50% of it in rehab. So these are pictures under anesthesia on the table, but the final range of motion is always not as good as what you get intra-op. And that's a discussion to be had with the patient to let them know that if you gain 50 degrees, they're probably going to end up a year down the road with a 25-degree gain. Let's look at another case. This time the HO is strictly anterior. So here's a patient with a traumatic brain injury, and the HO is living all in the brachialis. And you can see it's strictly anterior. So our target is to get to the anterior and medial aspect of the elbow. So we can't do it through that approach I showed you earlier, but this time we're going to make a an anteromedial approach to the elbow, identifying the ulnar nerve and the median nerve, and then getting them out of the way and putting vessel loops around the brachial artery, the median nerve, and ulnar nerve. And then we can get to the brachialis safely and remove the heterotopic bone. Here's what it looks like when it came out with a good restoration of range of motion. And another example of anterior medial contracture and problem is brachialis hematoma. So this was a patient who was snowboarding and ran into a tree and developed a large hematoma. And the problem here was a progressive neurologic deficit. So here on the plain x-rays, we don't see anything because it hasn't had time to ossify. So this injury is 3 or 4 weeks old. But on an MRI, you can see the hematoma forming in the brachialis and the osteoid, which hasn't yet ossified. So that's what it looked like. And the patient was taken to the operating room for an anterior medial approach and the release of the lacertus, identification of the median nerve and brachial artery, and then a resection of the heterotopic bone that was forming in the brachialis. And here's her range of motion. So we've seen some examples of elbow releases, and I'm going to switch gears now to talk about elbow arthritis. As you heard earlier, the average person who gets elbow arthritis is a middle-aged man, and they're either weightlifters or heavy laborers, because the elbow is generally not a weight-bearing joint. But if you make it a weight-bearing joint, you're going to get osteoarthritis, and you're going to get the typical osteophytes in the coronoid and the olecranon fossa. And here's what it looks like on X-ray with the thickened synovium and the anterior and posterior osteophytes that form in the coronoid fossa and the olecranon fossa. And probably my favorite procedure for this is the Outerbridge Kashiwagi or OK procedure, which can be done arthroscopically, but I'm not an arthroscopist, and you're going to hear from Dr. Kwon about great ways to do these releases arthroscopically, but I generally do them open. But if you are going to do a scope, that's an easy one because you get a straight posterior portal and there's not much danger in there, and then you can ream through to get to the front. But I typically do them open through a 2-inch incision and split the triceps and use a trephine to remove a piece of bone right out of the olecranon and coronoid fossa. Here it is on a K-wire, and you can see that creates a nice window in the distal humerus. And then by using a curved stiletto osteotome, you can go through that hole and knock off the tip of the coronoid, and using a pituitary rongeur, remove that bone. I splint the elbow in extension for 3 or 4 days, and then take the splint off and start them on motion, because it's always easier to get flexion back than extension with these elbow releases. So let's look at a case. This is a gentleman that came to see me, and this is his range of motion pre-op. And you can see he's got pretty good flexion. The only problem was he was missing that last 10, 15 degrees of flexion, and he was a preacher, and he couldn't tie his collar. So what he was looking for was just a few more degrees of flexion. And when I looked at his forearm rotation, it was okay, but there was a big medial bump on his elbow. So we took some x-rays, and here's what it looked like. He'd had a humeral shaft fracture that was treated with a hanging cast that went on to heal, but he ended up with a stiff elbow, and he went to see somebody for elbow release, and they removed a large portion of his olecranon. But he ended up with this large medial osteophyte. And what's keeping that elbow from dislocating is the triceps that was advanced, as well as the medial collateral ligament, because the origin and insertion on the sublime tubercle were preserved. So what are the treatment options for this? And I really didn't want to do a big release on his elbow, given that he was already missing half his olecranon. So I thought about the OK procedure. And here you can see, you can split the triceps, go in the back and remove that bit of bone, which then allowed the coronoid to go into its fossa properly and regain that last little bit of motion. Now, what about severe arthritic changes and loss of cartilage? Well, probably the best procedure for that is a total elbow arthroplasty. And you're going to hear from Dr. Virk about total elbow arthroplasty, so I won't talk about it. But I did want to bring up interpositional arthroplasty as an old technique that we should probably remember somewhere in the back of our minds. So here's a case that I did years ago with a piece of fascia lata that was harvested and then draped over the distal humerus. And I combined the interpositional arthroplasty with a hinged external fixator for 6 weeks to create a little distraction. And there's a case series of this operation being done with interpositional arthroplasty and hinged fixation. And initially it starts looking pretty good, but with long-term follow-up, it usually ends up looking like this, with sort of this unstable elbow. And I call this the nunchuck elbow because it kind of flops around. But it does provide pain relief, and in some rare circumstances is a consideration. All right, I'm going to switch gears now, and the final topic I wanted to talk about was synostosis. And synostosis is just a subcategory of heterotopic bone where you really get a synostosis between the radius and ulna. And it can happen at the PRUJ or at the DRUJ, or I guess anywhere in the middle. So this is a case, I call it when Harry met Sally, because it's like a Galeazzi and a Monteja combined. So you can see the comminution there and the elbow dislocation associated with it. So we started off by putting some plates on and fixed the shaft fractures and the radial head fracture and the distal radius fracture. And things looked pretty good, except over time, he formed a synostosis at both the DRUJ and the PRUJ. So here's a selected CT scan showing the PRUJ synostosis. And that's typically where it occurs, just near the biceps insertion. So here's the approach with using the old posterior approach. And you can see the Coker interval and the Kaplan interval lined out here. And so it's nice to go anteriorly and identify the posterior interosseous nerve. And there's the posterior interosseous nerve. And then once you have that identified, you can do a sub-anconeus approach going way from the back to get to the synostosis and expose it. And there's the synostosis between the radius and ulna. I always put in a K-wire, as you can see in the top left picture, to identify the synostosis before cutting it out to make sure I got the correct piece of bone out. And the same thing was done at the distal radial ulnar joint for restoration of the range of motion. So here's what it looks like with the hardware removal and the resection of the synostosis with restoration of pretty good range of motion. And the last case I wanted to show you is another combined injury with an ulnar humeral dislocation and a Monteja and a radial head fracture. And these are the 3D CT reconstructions. So we start off by plating the shaft just to build a little confidence, straight bone, straight plate. And then intraoperatively, these radiographs show the radial head arthroplasty. And you notice the endo button on the back of the olecranon, and that's used to tie back the capsule. So that restored stability to the arm, and things were looking pretty good for a little while. But by 6 months, he developed a large heterotopic bone mass and a synostosis between a radius and ulna. So here you can see in the holding area, all that rotation is really happening through the carpus. None of it's happening in the forearm. So the same approach was used. You go anterior, find the posterior interosseous nerve, and then you go posterior to get to the heterotopic bone and synostosis once the PIN is safely protected. There's a K-wire identifying the piece of bone that needs to come out. And then once the resection is carried out, you should be able to see a little sunlight between the radius and ulna, like you can see over here on the picture on the right. And that means that you've adequately resected the synostosis. So here's his range of motion after resection. And here's his flexion and extension arc. A word about prevention of recurrence. So once you remove heterotopic bone, we want to stop it from coming back. And probably the best treatment is radiation. And so if the patient can tolerate it, I usually set them up to get radiation treatment the day after their surgery. It's a one-time dose, 700 rads. And if there's some contraindication to radiation, you can try indomethacin, either the 75 milligrams slow release or 25 milligrams TID. I find it's hard for patients to remember to take a pill 3 times a day for 6 weeks. So, and the radiation seems to be a little more reliable. Postoperatively, you need to have enough stability to start early motion. So the collateral ligaments should be preserved whenever you can. And if you can't preserve them and you repair them, then I like the Hotchkiss overhead protocol, which protects the collateral ligaments. Here's a picture of what it looks like. Basically, the patient lays supine and they use gravity to help stabilize the elbow. So the elbow is held in a flex position with the shoulder adducted and the elbow is flexed to 90 degrees. You keep the forearm in a little pronation to keep everything stable, and then they can do a flexion extension motion with their elbow without any varus or valgus moment on the ligament repair. I used to use a hinged elbow brace, but I've gone away from that. I find that just the weight of the hinged elbow brace seems to drag the ulnohumeral joint down. So just a simple sling and then the overhead protocol seems to be very effective. All right. Thank you for your attention. It's a pleasure to be here.
Thank you very much, Dr. Paksima. Our next speaker is Dr. Young Kwon, who is an associate professor of orthopedic surgery at NYU. He is a member of the shoulder and elbow division and is a leading expert in complex shoulder and elbow procedures. He's going to be speaking about the arthroscopic management of elbow arthritis.
Thank you very much for the introduction. If we could put our slides up, and also kudos to Dr. Paksima. I never thought he was going to be able to go through 100 slides in a matter of 15 minutes, but somehow he was able to do it. So kudos. My talk won't be nearly as long as I just don't have as much nice things to say, I guess. All right, so this is in advance. Can I go back, I guess? Yeah. All right, so here's the title talk. So I'm going to be talking to you today about arthroscopic management of patients with elbow arthritis. I have no relevant disclosures. Elbow arthroscopy is a concept that we've actually known about for a long period of time. Actually, a surgeon from New York, Dr. Berman, used a 3mm endoscope and kind of used it to poke around various parts of the body. And he actually thought the elbow was not amenable for an examination or manipulation using the arthroscope. Obviously, many years later, one of our Japanese colleagues developed a smaller arthroscope, 1.7 millimeters, and then that allowed us access to other small joints, including the elbow. So really one of the earliest reports we have of elbow arthroscopy is from the Japanese literature, with Dr. Ito publishing in 1979 on his experience with 200 cases of elbow arthroscopy. In Western Europe and in the United States, elbow arthroscopy has gained a lot of traction, usually in 1980s and on, and was really Jim Andrews' articles in 1985 that was really the key and landmark article. He described all the arthroscopic techniques as well as relevant anatomy around the elbow that has to be avoided so that you could perform the procedure safely. And since this article was published in 1985, we've obviously now gone through various indications. So these are sort of the accepted indications for elbow arthroscopy. There's lots of these, and I'm sure these are also growing as well. Obviously, today we're going to be talking about treatment of patients with elbow arthritis. So as we've already been talking about, patients will present with different complaints when they have elbow arthritis. One thing to kind of mention, however, is that arthroscopic surgery can be very helpful for some of these symptoms. Unfortunately, it cannot take care of all the symptoms in patients with elbow arthritis. So not every patient with elbow arthritis will be amenable for treatment with arthroscopic surgery. So patients who have pain at mid-motion, I think that would be tough to deal with arthroscopic surgery. Patients who do have pain at extremes of motion, typically osteoarthritic patient with osteophytes, those are very amenable for arthroscopic surgery. Patients who have contracture from contracted capsule, those would be taken care of arthroscopically. If they have mechanical symptoms like locking or crepitus, arthroscopic surgery is great for that. If the patient has osteolytis synovitis, once again, arthroscopic surgery would be very good for that. But you do have to quite understand that not every symptom from elbow arthritis can be treated arthroscopically. So you have to understand how to counsel the patient and which patients would be appropriate. So if you do identify a patient that may be amenable for arthroscopic treatment, then imaging studies will be quite helpful. Typically, plain radiographs will kind of guide you along the path of whether or not this is an osteoarthritic elbow or possibly an inflammatory arthritis. If the patient does have osteoarthritis, CT scan will be very, very helpful, especially those with 3D reconstruction images, as has already been mentioned in the previous talks. But you can see the patients with significant osteophytes, they could be very, very readily identified through the CT scans. MRI could also be very helpful if the patients have a lot of soft tissue involvement, or if they have synovitis or plica formation that will not show up on a plain radiographs or CT scans. At least for the time being, ultrasound really has a minimal role in assessing or evaluating patients for patients with elbow arthritis, at least not in my practice. All right, so once again, to reiterate, arthroscopic surgery can be helpful in patients whose joint space is reasonably maintained. So you see a patient here with osteoarthritis. If you actually look at the CT scan, you notice that the joint space is actually not bad. This patient has osteoarthritis. He has contractures as well as locking, and you can see why. So if the patient has maintained joint space, but they have pain at extremes of motion because of osteophytes, we could take care of their arthroscopically. If the patient has significant loose bodies, once again, we could remove them arthroscopically. They could also improve the motion about the elbow by releasing the capsule and doing a capsulectomy. And we'll talk about that as well as I'm going to also show you a video of how that's also done. Actual procedure itself, the patient has to be positioned appropriately. I think one of the earlier reports used supine procedure, but this is fairly uncommon. Majority of patients these days are positioned either in prone or in a lateral position. Lateral position is probably the most common in the United States, and certainly the position that I tend to use. One of the things we do want to mention here is that if you do place the patient on a laterally, you have to open up and avoid putting any pressure on an anterobrachial space, because if you do, all the capsule would be collapsed against the joint, and you don't have much space within the anterior compartment to do your work. So you always have to make sure that you put minimal pressure on the anterior capsule. These are some of the portal sites. This is actually the picture that was published by Jim Andrews way back when. And basically, majority of this, the portals and the techniques are fairly similar. As was already been mentioned, you have to make sure that you have to avoid the ulnar nerve. So when you're making the anterior medial portal, if the ulnar nerve has been transposed, you can't go that way. And you have to find different ways to get into the elbow. All right, so to care of patients with arthritic elbow, you kind of need to know what a normal elbow looks like. So this is a sort of a video I put together just to kind of show what a normal elbow is supposed to look like. I'm looking anterior laterally from the anterior medial compartment. You can see the radial head coming across right there, maybe a little synovitis, but not bad. If you change the portal and you're looking medially on the anterior compartment, so you're looking at anterior lateral portal to look anterior medially, you can see the coronoid process coming along and the coronoid fossa as well as the distal humerus. And you can see all the cartilage surface is nice and shiny and undisturbed. Posterior laterally, you can look at the posterior aspect of the radial capitellar joint. And on the medial side of this, you can also look at the radial ulnar joint, and we're going to go through that later on. This is the medial aspect of the posterior compartment, and you can see where all the indentation is happening. That's the ulnar nerve. I was kind of playing with the ulnar nerve just to demonstrate to everybody how close the ulnar nerve is to the posterior medial joint line right there. Okay, so once you have an idea what a normal elbow is supposed to look like, we're going to now look at what an arthritic elbow could look like. So this is a patient of mine who had an osteoarthritis with significant bone spurs and loose bodies. He had a contracture as well as a lot of pain, mostly at extremes. In mid-motion, his pain wasn't too bad. So I thought that this patient would be amenable for arthroscopic surgery. I'm in anterior medial portal, looking laterally, and it is in the anterior compartment, but I'd like you to notice that you really can't see much. And the reason you can't see much is because the patient has lots of loose bodies that are all sitting in there. It's all really just a bag of marbles that is the anterior compartment here. So I have to remove all these loose bodies to even see the joint line. And some of these loose bodies could be fairly big. And I'm sure I removed at least 10 of these loose bodies just from the anterior compartment. And you can see how big that loose body is. Once all the loose bodies are removed, you can now see into the joint line, and you can see the radial head, and you can see the coronoid and the capitellum. On the anterior surface of the distal humerus, so within the coronoid fossa and the radial fossa, there's usually lots of osteophytes. And this is what's causing patients pain and limitation in terminal flexion. So when they try to flex the elbow, the radial head and the coronoid run right into this, and basically is causing a lot of pain and impingement-like symptoms. So you get rid of that. Once you resect the bone, then you work on the soft tissues. You try to do a contracture release, which means capsulectomy. So I'm going to take the anterior capsule, which is what you see there. I identify the space between the overlying muscle and the capsule, and I resect the capsule. Obviously, you have to be a little careful here because the radial nerve is nearby. But you could do it reasonably safely if you go slow using minimal suction during the arthroscopy. And another thing you should notice is how thick this capsule is. And once again, it's an osteoarthritic elbow, and this patient has very, very thickened capsule anteriorly, which is going to prevent extension of the elbow. Once the anterior compartment is addressed, we're going to then switch our portals and go to the posterior compartment. And I'm using posterior lateral portal to look into the olecranon fossa, but you don't see a fossa because of all the excess bone he had formed within the fossa. So once again, just like the anterior compartment, I have to get rid of all this bone so that I can start getting a better visualization of the olecranon and the olecranon fossa. Even after we get rid of some of the excess bone, you can see that he actually formed some osteophytes on the, he formed almost a secondary rim on the distal portion of the olecranon fossa. So that's not uncommon. We have to resect that. And clearly you can see that excess bone that's remained within the olecranon fossa. So I'm going to get rid of that with an arthroscopic burr here. Once the boning work is done, you try to address the capsule. So once again, now you can see the posterior capsule and see how thick that is. So once again, we come in with an arthroscopic biter and bite all that posterior capsule off. Once everything's clear, you should be able to now see the olecranon and olecranon fossa. So you can see the olecranon on the top and olecranon on the bottom, olecranon fossa on the top. At flexion and extension, you see that they kind of come and interarticulate without causing an impingement. One of the joints that are missed a lot during elbow arthroscopy is the radial ulnar joint. So you do want to address that if you can. So you go posterior laterally. So the arthroscope is introduced into the radial gutter, and that big osteophyte you see is between the radial head, which you could sort of see at the 1 o'clock position, and between the radial head and the proximal aspect of the ulna, the radial ulnar joint, there's a big osteophyte this patient had. So obviously I got rid of that. And then after that, the patient's generally able to move the elbow a little bit better. As I mentioned, you could get rid of all these osteophytes, especially for a patient with significant osteoarthritis. And if you do so, they do see a predictable improvement of pain. Even for patients with rheumatoid arthritis, if they are suffering from acute inflammation or acute synovitis, you could do a synovectomy arthroscopic, and these patients will also, again, do very, very well in terms of improving in their pain. What is not quite as predictable, as Dr. Paksima mentioned, is the gain in motion. Arthroscopically or in the operating room, you could get very, very good motion, but a lot of times the patients cannot maintain that motion. So I always tell patients that if you're going to consider doing arthroscopic surgery, you should do it to improve the pain. You will also likely get some additional motion, but whether you get a little more motion or you get a lot more motion is something that's just not predictable. So you really should do the surgery mainly to improve the pain and not necessarily to improve the motion. All right, so what are some of the literatures talk about? This is one of the original papers that were published back in 2007, so now 15 years ago. Small sample size of only 11 elbows at 2.2 years of follow-up, but all patients were younger than 50. So this is a typical patient with osteoarthritis who's been working out a lot and or have a severely heavy manual type of job. So these patients did great. Their flexion went from 100 degrees to 140 degrees, and their extension went from 40 to 7. So essentially, they gained 70 degrees of motion. Now, this kind of result, it really has not been duplicated at other institutions, but this was initially what was reported from this group from Texas. Later in the following year, this was a report that was published from the Mayo Elbow Group. And they had a little more patients, 42 elbows at 3.4 year follow-up, and they saw improvements in their flexion and extension. So total gain in their motion was about 30 degrees, so about 15 degrees flexion and about 12 degrees in extension. So they were able to get about 30 degrees additional motion. Their male elbow performance index went from 67 to 84, which would be good results. And their pain went from 2.9 to 1.4. Now, this was a 5-point scale. So if you're looking at VAS for pain, you just double that number. So they went from 5.8 down to 2.8. So a 3-point gain in the VAS for pain as well. They noted 2 complications. One was a small HL formation, and another one was transient ulnar neuropathy. Neither of these require a surgical intervention. Okay, so this is a more recent article that's been published from our Korean colleagues, and they did a comparison study. So earlier in their practice, I think they did a lot of open release. So that's the 35 patients they did an open release on. Later in their practice, they started doing a lot more arthroscopic surgery. So those are the 52 patients. So they're different in timing, but similar indications. The improvement in your range of motion was a little bit better for the open group. So they gained about 50 degrees. Versus about 40 degrees for the arthroscopic release group. But the Mayo Elbows Performance Index went up similarly, and their improvement in pain was also similar as well. Most recently, about 2 years ago, there was a systemic review of all the published articles comparing arthroscopic versus open release for patients with elbow arthritis. Once again, they noticed improvement in VAS for pain. They also noticed improvement in the motion as well as Mayo Elbow Performance Index. The improvement in motion was a little bit better, at least in the open group, at least for flexion, the improvement was a little bit better. So perhaps open release may be a little bit better in terms of pain and flexion of the elbow than arthroscopic techniques. So to summarize, as we mentioned, obviously patients suffer from various degrees of arthritis, and they have various symptoms. Unfortunately, arthroscopic surgery is not amenable for every symptom. It is good for patients who have pain at extremes of motion, those who have contractures or any mechanical symptoms, or they have acute inflammation. So we do have to kind of individualize the treatment pattern for every patient and try to treat their appropriate symptoms. And if arthroscopic surgery is considered, obviously we have to make sure that they have the symptoms that we are able to address adequately. Thank you very much.
Thank you, Dr. Kwon. That was great. Our next speaker is Dr. Madeep Virk, who is an associate professor of orthopedic surgery at NYU and also a member of the shoulder and elbow division. Dr. Virk will be speaking to us about total elbow arthroplasty.
Thank you, Dr. De Tolla. I want to thank Dr. De Tolla and Dr. Paksima for giving us an opportunity to participate in this webinar. So I have been assigned the task of talking about total elbow arthroplasty in the next 15 minutes. It's an extensive topic, but we will go over more pertinent things related to total elbow arthroplasty. So my disclosures are on the AAOS website, and none of the disclosures pertain to today's talk. Like any other joint arthroplasty, total elbow provides a satisfactory pain relief, improvement of function, and provides stability. The goals of total elbow are to restore anatomy, joint mechanics, and provide stability. So going into a little bit of history of TEA, the first series of modern total elbows were presented by Dr. D, although there are reports of total elbow arthroplasty in early 1950s, especially for, believe it or not, fracture indication. The earliest design was a rigid linked constrained implant, which had a high rate of loosening. This paved way for the modern designs, which are semi-constrained link implants and unlinked implants, which we'll talk in a few. We all know that total elbow is less commonly performed than other major joint orthoplasties, with an annual number of TEAs performed in the United States around 1.4 per 100,000 population. In the last 2 to 3 decades, there have been trends that are worth noting. There have been significant increase in utilization of both the primary and revision total elbow in the last 2 decades. There have been changing trends and indications for total elbow. When it was originally introduced, it was more for inflammatory pathology like rheumatoid arthritis, which still constitutes a significant chunk. But in the past decade or more, trauma has been slowly climbing up and is another major indication in non-reconstructible fractures in selected patient population. Women as a gender continue to have higher utilization of total elbow compared to men, more so related to the inflammatory pathology. From a design perspective, there are 2 designs, broad categories, the linked and the unlinked design. The linked design, as the word states, there's a physical mechanism that links the humeral and ulnar components to provide stability. These are more popular in the United States. The first generation was a highly constrained design with a rigid hinge, and it had a high failure rate due to increased stress on the implant cement interface. The more modern designs are the semi-constrained sloppy hinge design, which allow for varus valgus laxity and take some stress off the cement bone interface, but then they pass on that stress to the bushings. They are more preferable in revision cases where there's bone loss, and primary total elbows where, again, there's a considerable bone loss or ligament insufficiency or severe stiffness. The other alternative is the unlinked design that's more popular outside the United States and Europe. It does not have any kind of a mechanical link, so it's relying on the architecture of bearing surfaces, the ligament integrity, and muscle tension to provide stability. Again, linked and unlinked should not be confused with constrained and non-constrained. But unlinked, majority of designs are less constrained, so they have theoretically less wear and osteolysis. But unlike the linked designs, they do require good bone stock and ligament integrity in order to have the appropriate tension to work as an unlinked design. Therefore, they are desirable in selected younger patient population because of the advantage of more longevity, which we have not been able to prove yet. Elbow joint is, we all know, a pretty complex joint. So total elbow arthroplasty continues to evolve in order to match our ever-growing understanding about this joint. We have thicker polyethylene components now. We have modularity in terms of convertibility between a linked and an unlinked design. Radial head replacement is still not a uniform feature and not available on all designs, but preferred in unlinked designs. And we are predominantly using cemented components, although there are uncemented components available, which in their initial studies demonstrated a high rate of failure on the ulnar side. This is just a slide showing the linked and unlinked components based on their constraints. So there are certain anatomic considerations both on the humerus and the ulnar side, which we should be aware as surgeons performing total elbow arthroplasty. On the humerus side, in the sagittal plane, the distal humeral articular surface is directed anteriorly approximately 30 degrees relative to the humerus shaft, and that design is captured in our modern day stems. In the coronal plane, the articular surface has valgus angulation to the long axis. And again, you can see we have those things built into our designs. The anterior bow of the humerus shaft, one should be mindful, especially when doing revision cases. And, some surgeons will actually, for long stems, give them a little more of the bow intraoperatively in order to make sure they don't perforate. Likewise, on the ulnar side, there is valgus angulation of proximal ulna relative to the long axis, which again is incorporated in the designs. And similarly, in sagittal plane, there is dorsal angulation of the proximal ulna called the Puda angle that we are aware for our platings and in Monteggia fracture dislocations. And our current designs also take into consideration this difference, not difference, but this peculiar anatomy in the ulna. From a joint kinematic standpoint, we all know that elbow does see a lot of stress during routine activities of daily living. There are 2 degrees of freedom, the flexion extension and supination pronation. Now, flexion extension occurs along the flexion extension axis that runs from the center of the capitellum to the junction of the medial epicondyle with the trochlea. During total elbow, we need to recreate a flexion extension axis with our artificial implant in order to have an impingement-free range of motion. When total elbow was initially introduced, it was primarily for inflammatory arthropathy, of which rheumatoid arthritis constituted the major chunk. An ideal patient for total elbow is still an elderly patient, more than 65 or even more, low demand, who can understand the lifting limits associated with total elbow. As I mentioned, indication-wise, inflammatory arthritis, the relative prevalence of total elbow for this indication is decreasing, but it still forms a significant chunk. Non-reconstructible distal humerus fracture is one of the expanding indications that is becoming relatively more common and inching closer to actually inflammatory arthropathy. Both acute fractures that are non-reconstructible or non-unions in elderly population. Post-traumatic and primary osteoarthritis are still the indications, but not as common as the former 2. This is a patient of mine, end-stage rheumatoid arthritis as an indication, getting a total elbow. Another patient with a late presentation of a non-reconstructible distal humerus fracture, 75-year-old, gets a total elbow. From a preoperative standpoint, there are important considerations that one should be aware of. You should know patient's lifestyle, smoking history, comorbidities, all of which have a bearing on the outcome of total elbow. It's difficult to assess whether the patient is going to comply with postoperative lifting limits. Everybody, nods their head in terms of understanding, but we all know once pain is relieved, patient do not adhere to the instructions that well. If a patient requires upper extremity assistive aids for ambulation or balance, is not an ideal candidate for performing total elbow. Prior surgical scars do go into account when you're selecting an incision to do a total elbow arthroplasty. You should be on board with your rheumatologist to make sure that the biologics and other disease-modifying agents, they are stopped prior to surgery in order to prevent any wound complications. Again, if you're doing an unlinked total elbow, assessment of bone stock ligament integrity is important. And if you're going to be doing a radial head resurfacing in an unlinked design, you want to make sure you know the status of radiocapitellar joint. In next few slides, I'll go through the important components of the surgical steps and my preferences. For me, it's a supine position with arm across the chest and a bump under the shoulder so that the arm tends to stay forward across the chest. This can be done in lateral position as well, although your anesthesiologist is going to be more happy in a rheumatoid patient with a neck that may not be as stable to be doing in a lateral position. Tourniquet for me is sterile. Non-sterile tourniquets can be used, although they've shown to have a higher rate of infection or contamination. For me, the surgical approach is a posterior midline incision unless I have prior surgical incisions that I have to modify during surgery, at the time of surgery. I routinely dissect and transpose the ulnar nerve, although there are surgeons who do not transpose the nerves. Management of extensor mechanisms, still an ongoing debate, no ideal technique. There are three commonly used techniques that I'm going to go over. The classic tricep reflecting Brian Morey technique, in which the tricep and the forearm fascia is peeled off as a single layer from medial to lateral side. Definitely provides a wide exposure, but you have to be very careful when you're peeling off the tricep insertion of the olecranon, because it can sometimes leave a buttonhole in that part of the flap, which can also predispose to lateral subluxation of the entire mechanism. Doing transosseous repair technique, as shown by Dr. Morey, will definitely help reduce the incidence of that complication. Tricep on approach is definitely technically more challenging, but does allow an advantage of early rehab because you don't have to protect the extensor mechanism. In this, the tricep insertion is left on the olecranon, and you create two medial and lateral windows, which are paratricipital, and you can work on the humerus and ulna. Definitely, working on the ulnar side is much more technically difficult. But for me, this approach is really a good approach if you're doing distal humerus fractures or if you're assisting your oncology colleagues for total elbow after a tumor resection. Tricep split can be a longitudinal split, but again, you have to distally take the tricep off its insertion, and runs into a similar situation like the reflecting approach. My go-to approach is the V-shaped tongue approach, in which distally at the muscle tendon junction, slightly distal to that, you're taking a V-shaped tongue of the tendon, and then you're extending distally so that you can reflect the proximal part and approach the distal humerus and the ulna. There are modifications to this approach, but this seems to work well for me in non-trauma conditions. Continuing with the surgical approach, you do, once you have addressed the ulnar nerve and the extensor mechanism, you release the collateral ligaments to dislocate the joint, radial head resection, again, based on your preference and the indication that you are treating. And then you finally move on to the ulnar and humeral canal preparation. It's a matter of preference, whether you want to do ulnar first or whether you want to do humerus. The humerus preparation typically goes through a series of steps that involve humerus fossa osteotomy in order to gain access to the medullary canal, reaming, broaching, and trialing. So important considerations when you're working on the humerus side is that the distal most part of the humeral implant should be at the flexion extension axis that goes through the center of the capitellum, and on the medial side, junction of the medial epicondyle with the trochlea. It is not the distal most tip of the articular surface. And it's important to seat the implant so that it can be at that level of the flexion extension axis. Use a barrel reamers or burr, especially at the junction of the condyles with the supracondylar ridge, or where the implant typically gets caught at. So you need to take your time and make sure that you can recess it appropriately. Again, when you're broaching the humerus, you got to be mindful of the relationship of distal humerus with the axis of the humerus so that you can incorporate sufficient internal rotation when you're broaching. Likewise, on the ulnar side, same canal steps, entering into the medullary canal, reaming, broaching, and then trialing. Again, important considerations on the ulnar side. Now, ulnar side is more difficult. The ulnar canal is always tight, so flexible reamers are really helpful to avoid any cortical perforation. In order to gain access into the medullary canal, I think use of a burr at a good 45 degrees angle is a good tip to get in. Resecting the tip of the olecranon so that once you are into the medullary canal, you can have a straight shot down the ulnar canal as shown in this slide. Now, ulnar implant sits on the coronoid. So you want to avoid over recession and you can resect the tip of the hypertrophic coronoid to avoid impingement and extension and flexion, respectively. Again, you want to make sure that you recreate the center of rotation on the ulnar side. When you're broaching for ulna, unless you have a reflecting approach, the tricep reflecting, but if you're doing a tongue or a tricep on, it becomes really hard to know how the rotational alignment of the broach is. So using the back flat part of the proximal olecranon and having your flange of the broach parallel to that is actually a good technique when you are broaching the ulna. So prior to implantation, always do a trial run of implants. Make sure there's no impingement. Make sure the flexion extension is restored to the best. And once you have made sure there's no impingement, you can proceed with implantation of the final components. Irrigating the humeral and ulnar canal, place cement spacers. You should make sure that you have all side cement spacers for humerus and ulnar side. And you have an option of either cementing humerus and ulna as a separate event using separate batches of cement, or you could do both of them together from a single cement batch, which in the beginning can be a little nerve-wracking when you're trying to get the implants at the appropriate level. But as your comfort level increases, I think putting both those implants in, and I use unlinked implants. I use linked implants, and putting in a linking mechanism allows you to extend the elbow, hold it there till the cement sets in, and minor rotational alignments actually find their happy spot, and it actually works well that way. Again, we use antibiotic impregnated cement to minimize the risk of infection, which is definitely an issue with total elbows. So post-operative immobilization, important. In the immediate post-operative period, the goal is to minimize edema, protect and promote wound healing. Immobilization and extension is what I prefer. Some people use an anterior slab in order to keep the elbow in extension. I do use drain, take it out on day one. And if you are using a tricep on approach, you can, and you're using a linked mechanism, you can start passive and active motions right away. If you have done a tongue approach, you definitely want to protect your repair, but gravity-assisted passive extension can be started relatively early. It is very important pre-operatively and post-operatively reminding your patients about the lifting limits, which are typically 2 to 4 pounds of a repetitive load limit. I am more on the lower side of 2 pounds when telling my patients. And then a maximum lifting limit of 5 to 10 pounds, which is reported in literature. Again, I'm on the lower side. Again, for patients, it's important to tell them lifting weight in line with flexion extension axis is much more forgiving compared to holding weight in abduction, in which you are really stressing the linking mechanism. As far as outcome and survival, we all know that total elbow is not as effective in terms of survival compared to total hip and knees, but still patients can expect satisfactory pain relief. Recent systematic reviews show that 60% patients are pain-free at a mean of 6.3 years. There is considerable improvement in range of motion. Patients can expect 100 degrees of flexion extension arc and supination pronation arc after total elbow. Extensor lag is definitely related to your triceps weakness or insufficiency, and achieving extension is definitely more difficult in certain indications compared to others. If you look at the overall survival of total elbow, we can easily, based on all the studies and recent meta-analysis, go a good 80% survival at 10 years. And these numbers decrease as we go to 15 and 20 years. There are minor differences in the survival of linked and unlinked implants, but still, we are not at a scientific consensus if one implant is better than the other. Early revision infection is the most common cause. Late revision aseptic loosening is the most common cause. And if you look at the risk factors for revision, From an etiology perspective, post-traumatic OA is definitely at a higher risk of failure compared to other indications. From an implant design, as I mentioned, the problems may be different, but from a survival standpoint, one implant is not better than the other, at least has not been shown. Cementless fixation of ulna, definitely a problem shown in early studies. Younger patient age, definitely a high risk factor for early loosening. Patient-specific factors that have been shown to affect survival, obesity, diabetes, and smoking. So, they say that total elbow is a gift that keeps giving, and that is because it has got a high complication rate compared to other joint orthoplasties. Even though in last 1 to 2 decades, the numbers have dropped, but still overall, they're pretty high. Loosening, mechanical failure, instability, and prosthetic infection still account for a big chunk. And periprosthetic fractures, intraoperative and postoperative, are also a concern, especially tight canals, osteoporotic bones, revision with long stems can definitely predispose to a higher risk. Wound complication and hematoma formation, definitely their incidence is slightly decreased because of good soft tissue handling, use of drains, extension splinting, and the initial part of the recovery and use of antibiotic impregnated cement definitely has helped. Extensive mechanism insufficiency and ulnar neuropathy are underreported. They are much more common. Ulnar neuropathy in majority of cases does resolve over 6 to 9 months, but definitely underreported. Again, this is a slide showing the changing trend in the incidence of complications before 90s and then in 21st century. So again, as I mentioned, wound complications can be subtle with just small abscesses, or can be a periprosthetic joint infection. Again, this is a patient that I took care of who had an acute periprosthetic infection, debrided IND, component retention, poly exchange, but the patient continued to have recurrence, failed few INDs, failed antibiotic suppression, and eventually, underwent an explant. Another patient who had a total elbow done for a fracture indication several years ago prior to presentation. She came in with a painless bump on the outside of her elbow, and this is what the X-ray looked like. Again, a CT angio did not show any involvement of the vasculature, and this was revised to a long stem. In conclusion, total elbow provides satisfactory overall improvement in pain and range of motion. In last 2 decades, the usage of primary and revision total elbow is increasing. Improvements in soft tissue handling, surgical technique, and implant design have lowered the complication rate, but they're still high compared to other joint orthoplasties. The indications are expanding. Inflammatory arthritis is less common as an indication, and fractures are climbing up the ladder as far as the indications are concerned. Comfortable to quote a survival of 80% at 10 years for total elbow based on multiple studies. Some differences with respect to survival among the designs, but nothing that stands out. There's still no consensus on the ideal tricep management or an implant choice. Insufficient evidence to demonstrate superiority of one design with respect to indication, complications, and survival for primary total elbow. Thank you very much.
Thank you, Dr. Virk. That was excellent. So now we are going to move over to questions from the participants. The first question is, what is the order of management when you have multiple joint involvement in a patient with rheumatoid arthritis, if the joints are comparably involved? So I guess for our speakers, if the shoulder and elbow are involved, what's your order of management?
The general principle is, in my mind, start proximal and then go distal. But I think shoulder and elbow are a toss-up. As it comes to elbow compared to hand, I would say it's probably more important to do the proximal stuff first.
Yeah, for me too, the more painful joint I will address first. If there's a lot of deformity in the elbow, then I'll do the elbow first, but that doesn't necessarily mean that I'm doing an elbow arthroplasty.
Yeah, same with me. I usually just essentially take care of the more symptomatic joint, at least in the upper extremity, because and everybody's functional capacity is different as well. So basically, I think patients are going to tell you, they're going to either say the shoulder hurts more or the elbow hurts more, or they're going to tell you that I think if I do the shoulder, I'll get more use of the arm versus if I take care of the elbow, I get more use of the arm. So those functional use of the arm and the pain level is usually what dictates what joint I go after first.
And it's interesting that even if patient has a bad elbow, I've seen them picking up the shoulder despite the elbow looking much more bad compared to the shoulder.
Right. Well, there are patients who say, my elbow is limiting me and I can't reach my face, but their elbow they could get to 90 degrees. The reason they can't get there is because they can't raise your arm.
Yeah.
So if that's the case, then you take care of the shoulder first. But like I said, so functional use and the pain, those are the determining factors.
Okay, cool. And Dr. Paksima, when we're thinking about patients who need reconstructive surgery for their wrist and hand, I think the general principle, like you said, is address, if the elbow's involved or the shoulder's involved, address that first and then address the hand and wrist issues because of rehabilitation, correct?
Yeah, exactly right. And also, for specifically with wrist versus finger, if your wrist alignment is not adequately stabilized, then it's hard to get rid of the ulnar drift and do MP arthroplasties with a wrist that's in a lot of radial deviation and intercarpal supination. So, in general, you need a stable platform to work on. So we would start at the wrist first and then the fingers. That's typically what I've done, although I think that's not a really hard and fast rule.
Okay, great. There's a question from someone, how has the rehab protocol changed? I'm not sure what they're referring to. If they can follow up with a secondary question, we can answer that.
Just in terms of rehab, I wanted to say, that overhead protocol, for me, that's the one thing that's really changed. Because, I used to, whenever I would take down a collateral ligament, I would always use a hinged elbow brace. And I've gone away from using hinged elbow braces and really gone to just using the sling and using the overhead protocol with the patient supine. And that seems to really be very effective, and patients respond to it well, and it seems to be pretty safe. So that's one thing that's changed for me. I don't know if anyone else is still using hinged elbow braces, or what thoughts you have on those.
So I'll take that. So for my open elbow contracture releases, I do an LUCL sparing approach. So for me, I just let them do their flexion extension or supination, pronation, just in a sitting position or whatever the preference of the therapist is. So I don't have any restrictions on them. I don't immobilize them. I just put them in a sling, simple sling, for just one day till the block wears off. And they usually have physical therapy set up before surgery to start within 1 to 2 days. And I use a similar protocol in my arthroscopic elbow releases as well. Question for you, Dr. Paksima. So have you seen any elbow instability after releases in which the LUCL is taken down?
It's generally not a problem because the patients who have elbow contractures, post-release instability is generally not an issue for them. But it certainly can be. I can remember a case or two, but those were related to postoperative complications where if they developed a large intra-articular hematoma, then there was some instability, associated with the expanding hematoma that sort of like flew up the elbow. But in general, they seem to be okay. If I take it down, I take it down as a big sleeve and I just put it right back together with a suture anchor. And once you put that sleeve together, it seems to be okay. I can't remember a case where I've had to go back and reconstruct with a tendon graft or an internal brace for post-release instability.
Do you limit, so in the overhead motion protocol, I use that if I ever release the LUCL or if I have to repair it in the setting of instability in trauma. Do you limit elbow extension at all in the immediate postoperative period if you do a contracture release LUCL and then repair it? Or do you just let them?
Yeah, generally I don't, unless, they were specifically unstable at a certain range. So, if once you're finished, if they're stable throughout an arc of motion, then there's no reason to restrict them. And most people are going to self-restrict to about 30 degrees anyway.
Do any of you think that there's a role for the internal joint stabilizer in contracture release for post-traumatic arthritis?
I haven't used that, so I can't tell you whether or not it's going to be necessary. So I guess I don't know all the benefits of that. But I could also tell you that I rarely use external fixator as well. Generally, if you have an unstable elbow, you take care of I go laterally, take care of the elbow, whether it be fractures or the ligament tears. And once you take care of that, and if the elbow is still unstable, you go medially and take care of whatever soft tissues you could take care of. I haven't had those ever be unstable to the point where I still need to supplement that with an external fixator. So I literally haven't used an external fixator for a long time. So since I don't use an external fixator, it's unlikely that I'll be using an internal fixator.
And then I have a question for Dr. Virk. You said you do ligament sparing, if you do an open release, ligament sparing release. Has there ever been a time where you haven't been able to achieve full extension if you didn't release the collaterals, or do you feel like you can still kind of regain full motion if you leave that on?
So it depends on what extent of deformity it is. So if you have a very severe deformity and you feel like, the flexion is like, you are dealing with 70 to 50 kind of an arc of motion, you can go from a medial side. You just do the medial approach. It's a similar thing. It's going to get you the same kind of releases. In addition, you'll be basically staring at the deep part of the collateral ligament. But from the lateral side, like Dr. Kwon said, it's mainly, even if you do an open elbow release, it's a pain relieving operation where the pain relief that happens is for an extreme range of motion, because that's where impingement happens. In mid-arc, either you have an arthritis, which is intrinsic, or a rheumatoid that's not going to get benefit that part of the pain, unless, you have more of locking, catching from loose bodies. But for mild to moderate contractures, if one is not comfortable with the arthroscopic release, I think the lateral LUCL sparing, you can even leave the anterior and posterior flap. You don't even have to close them to the lateral column where you have spared the ligament, and you still will be fine. It's more for hematoma and for other reasons that I will, in the end, close the anterior, which is the brachial flap, and posterior tricep back to the LUCL V, which you make, but haven't had an issue with that. So again, long-winded answer. If it's a very severe deformity, you think that when you'll do a full release, ulnar neuritis symptoms may be an issue, another thing, go medial, and you can do all those things that you were mentioning would be an issue from the lateral side. Mild to moderate, all can be addressed from the lateral side.
Yeah, so for an open release, if you keep the LUCL on, you still are able to get to the anterior compartment fairly easily. That really shouldn't get in the way unless you got some big HO or something. Yeah. So anterior compartment, you could get there with LUCL on. You actually don't need to take that off unless you're really trying to go medially. It's a posterior compartment that's a little more difficult. So usually if I'm doing that, I'm really worried about posterior compartment. I cheat the incision a little more posteriorly. So I still maintain the LUCL, try to get that posterior laterally. And if that really doesn't work, you could just raise a skin flap and kind of split the triceps as if you're doing the OK procedure, and you could get rid of a lot of bone spurs that way as well. So I haven't, like I said, needed to release LUCL if it wasn't already damaged for any kind of contracture release.
And then for Dr. Kwon, or I guess everyone, Do we know what the long-term outcomes are for elbow arthroscopy or synovectomy in rheumatoid arthritis? And is there a role for like a repeat synovectomy? Do those patients do okay?
So Nadir's older than me. I think he's been around longer, right? You were here before I got here, right? I think. Okay, so I could tell you. So I don't know what Nadir's experience is. The arthroscopic synovectomy, for whatever reason, seems to work very, very well for me. And these patients are, remember, the rheumatoid patients, so they have high tolerance for pain. So if they're coming and seeing you, they're really hurting. And if the joint space is reasonably maintained and their elbow is warm to touch and MRI confirms the synovitis, I do recommend a synovectomy. I have not seen, I'm trying to think back, I don't remember seeing patients that I did an arthroscopic synovectomy come back to me to another synovectomy. Now, we live in New York. It's very possible they just went and saw somebody else, right? They say, well, that Kwon guy didn't know what he was doing. Synovitis is back. But it's hard for me to believe that all of them have. So, the disease modifying drugs are so good these days. If you definitely have a patient who's still on those medications with a good rheumatologist who could adjust all those medications accordingly, and they just happen to have an elbow that was, had a lot of acute inflammation, you take care of that surgically, right? They usually don't come back. Unfortunately, I don't have good literature to support my theory.
No, I agree, and there are a case series of open synovectomies combined with radial head arthroplasties specifically for rheumatoid arthritis. There was the large case series out of joint disease, and they hold up. The X-rays look funky, but they hold up, and patients don't come back for additional synovectomy, especially with the new medications. So I think it's a very good operation with good longevity.
Right. It's a bit self-serving, but I wish I could tell our rheumatology colleagues that an arthroscopic synovectomy, at least of the elbow, is an operation that seems to work well. And they're under the impression that the patient should only have surgery if it's something's really, really dire. And I get that. I can understand why they want to. But if it's really monoarticular disease and it's just the elbow that's synovitic, I think there's arthroscopic synovectomy really does seem to provide very, very good improvements. And my only real concern is you try to do a synovectomy and you go in and realize there's zero cartilage remaining, and you're just setting the patient up for an elbow replacement in the future. So I wish I could get there a little bit earlier, but that's a difficult argument to make with a rheumatologist coming from a surgeon, right? Because it's unfortunately self-serving. So.
In arthritic elbows, I think there's good evidence that for 7 to 8 years, patients are relatively pain-free and they don't go in for a second arthroscopic treatment. But that's more for primary OA and not necessarily the synovectomy.
Okay. Awesome. And then let's see. Dr. Virk, for complications related to total elbow arthroplasty in the post-traumatic setting, do we know why the complication rates are so much? Attendees for joining us tonight. So thank you very much, everyone.
Thank you very much.
Thank you for having us.
All right. Thank you, guys.